Hello and welcome. I'm Joe Merola. I'm absolutely delighted to be with a dear friend and colleague here for Medscape presenting our masterclass in psoriatic arthritis. Alice, I'll turn it over to you for introductions.
I'm going to talk about the key importance of dermatologists in preventing disability due to psoriatic arthritis. So as you see on this slide, be a hero, and your patients will think you are a hero for doing it. So we're going to talk about diagnosing psoriatic arthritis for the dermatologist and making a real difference in our patients' lives. And I'll show you that it's easy. Okay, as you know, both Joe and I are dermatologists and rheumatologists, boarded in both. I'm at Mount Sinai in New York City, and Joe Merola is chair of dermatology at the University of Texas Southwestern Medical Center. Here are disclosures. I'm going to say for myself, my biggest disclosure is my mother of blessed memory, who had psoriasis and psoriatic arthritis and was truly helped by one of the drugs I helped develop. So I am grateful to these companies for giving us these great drugs. And here's, from my point of view, my most important slide. So psoriatic arthritis is common. It occurs overall in about 25 to 30% of patients with psoriasis. And in most cases, it's not hard to diagnose. If you make the mistake and you give the rheumatologist an osteoarthritis, rheumatoid arthritis, fibromyalgia patient, they need a doctor too. So you haven't done any harm, you've done good. However, if you miss a psoriatic arthritis patient, you may make the wrong treatment choice and do the patient harm. Why? Because psoriatic arthritis is potentially disabling. And it's a real shame that psoriatic arthritis frequently gets undiagnosed, up to 41% in dermatology practices. And it's even more of a shame because we have a lot of time to make that diagnosis. The cutaneous disease precedes the arthritis in 84% of patients by 10 or 12 years. So who's the first doctor who really can detect arthritis? It's a dermatologist. This is not the responsibility of primary care. It is our responsibility. And why does it matter? Because we have TNF blockers, IL-17 blockers, and JAK inhibitors that not only control signs and symptoms, but they actually inhibit radiographic progression. So by diagnosing psoriatic arthritis early, we can prevent disability by initiating the correct treatment early on. And also, I don't see how you can treat psoriasis if you don't know if they have psoriatic arthritis. So if somebody has a little bit of psoriasis, which many psoriatic arthritis patients have limited disease, and you give them a topical steroid and you don't even ask about their joint complaints, you will have missed an essential part of the diagnosis, and you may do harm because you delay diagnosis. And which brings me to the point that although people with moderate to severe psoriasis tend to have more likely to have psoriatic arthritis, there are patients who have almost no psoriasis who basically have a bad psoriatic arthritis. Here are the domains of psoriatic arthritis: peripheral arthritis, signs and symptoms; axial disease, spinal disease; enthesitis, inflammation where the ligaments and tendons insert into bone; dactylitis, fat sausage fingers are caused by inflammation of the whole finger or toe unit; obviously skin and nails. And this Dr. Merola developed with his team in terms of an easy physical exam. It's as easy as PSA. P, pain and joints. Stiffness, it's either prolonged stiffness after a period of inactivity, at least 30 minutes, when waking up after a long car trip. Sausage digits is the same as dactylitis. And axial disease, this is spinal disease that is associated with stiffness that is exacerbated by inactivity and improves with activity. If two or more of the above are present, then a formal screening for psoriatic arthritis should be completed. And thank you, Joe, for this easy physical. But there are doctors who don't really want to do anything to diagnose psoriatic arthritis. So we developed at IDIOM a methodology so that the patient does most of the work, if all the work. And so this GRAPPA app is available for free, and it includes two tests. One is the PEST test, which is a 5-question questionnaire for a screening for psoriatic arthritis. If the patient answers 3 or more positive on that screen, they could have psoriatic arthritis. They do this before they even see the doctor. If that patient has positive pest tests with an explanation, they are handed the PSET, which is a 12-question symptoms and impact tool to assess both the actual symptoms of psoriatic arthritis and the impact on the patient. And the application calculates the score automatically. It is available for whatever gizmo a patient has, or a doctor for that matter, and it's translated into many languages, as you can see on the slide. So how do we put this into practice? So this was developed at IDIOM again, and you take a psoriasis patient, it would be recognized by their diagnosis code. If they either have a rheumatologist diagnosis of psoriatic arthritis or they screen positive on that pest test, they get handed with an explanation the PSET. If the PSET score is less than or equal to 4, shown in green here, we are doing a great job for psoriatic arthritis, so we can continue treatment. However, if the patient has a score of more than 4, we're not doing a great job, and we either modify the treatment ourselves or co-manage or refer. And we put this into effect in our EPIC EMR in Mount Sinai. And you can see here, this is done before the doctor sees the patient. So this is done by the patient, and the work for the doctor is minimal, if none. So here's the pest. You can see that this patient has answered 3 out of 5 questions positively, which means they could have psoriatic arthritis. Then the patient, as you can see the explanation, why you're being asked to complete this questionnaire. This is the PSET. And I can go over this is on 2 pages. You can see this patient is in terrible control because they have 9 out of 10 answered on every one of these. So pain, fatigue, skin problems, work or leisure activities, functional capacity is impaired, discomfort, sleep disturbance, coping, anxiety, embarrassment or shame, social participation, depression. So what happens when the doctor opens a chart? Remember, the doctor hasn't seen the patient yet, okay? This patient did not have a good pest score. It was greater than 3, and their PSET score was greater than 12. So when the patient is roomed, up pops a yellow message that says, your patient could have psoriatic arthritis. Click here for a rheumatology consult. You can't make it easier than that. And then if their PSET is not in target and that score is greater than 4, again, up pops a message that says, would you like to have a rheumatology consult? Click here. And you can click there. And you can also get a list of what all the FDA-approved drugs for psoriatic arthritis. And these are having very positive results in improving diagnosis and outcomes in psoriatic arthritis, which we're actually going to be presenting at the SID meeting in May. And with that, I'm going to turn this over to my very wonderful and famous colleague, Joe Merola.
Thanks so much, Alice. That was great. So at this point, hopefully you feel comfortable with screening your patient for psoriatic arthritis, maybe even making that early diagnosis. And as Alice already said, we really can't consider the treatment or an appropriate treatment for psoriasis if we don't know if the patient has psoriasis. This is a little diagram just to remind us of that. You can see at the top a patient with plaque psoriasis comes in to see you, and perhaps you're trying to decide on the appropriate therapy. On the left-hand side, you can see if a patient does not have psoriatic arthritis, we may go down an algorithm thinking about how severe is their skin disease based on a variety of criteria as shown. But the key branch point here is, does the patient have psoriatic arthritis? If they do, we're already thinking about pivoting early to systemic therapies or combination therapies, facing both skin and joints, for example. So that really is a key decision branch point in the treatment algorithm for us as dermatologists. Now, in 2024, you may say, well, how do I choose an agent? Maybe I feel comfortable that the patient has psoriatic arthritis. I've made a diagnosis and I'm trying to choose the right agent. Or I'm collaboratively treating this patient with a rheumatologist or other provider. How do we align on which therapy would be best to manage both their skin, their joints, and other domains? The first answer is we make that decision based on which domain of disease is predominant, is present in a given patient. Now, this looks like a busy slide, but bear with me. I'm going to take you on a brief tour And then we'll have a sort of simplified version of this, and we'll wrap up with some ideas about how we can approach the therapy of our patients with psoriatic disease. So without going into great detail, you can see here, and Alice already shared with us the domains of disease: peripheral arthritis along the top, skin and nail disease, axial or spine disease, dactylitis, that sausage digit, enthesitis, inflammation of sites of tendon insertion into bone or ligament insertion into bone. There were two domains added by the GRAPPA group, IBD and uveitis, that are more common comorbidities of psoriatic disease that we have to consider. I won't go through every mechanism on the left, but I want to start looking at some of both the small molecules as well as biologics. And you can see with regard to peripheral arthritis, many of those agents are FDA approved for psoriatic arthritis with a few caveats. So we'll come back to that. But you can see the check marks where they are an approved therapy for peripheral arthritis. We'll come back to the nuance. When it comes to skin and nail disease, we do have a good number of head-to-head studies that would suggest differential efficacy across these different classes. And then it becomes a matter of discussion with the patient about what is their preference for route of administration, for dosing frequency, et cetera. Some of our highest efficacy drugs do include the IL-23 and IL-17 inhibitors, for example, in head-to-head studies. But there may be relevant use of apremilast and other mechanisms, TYK2 inhibition, for example, in the skin. With regard to axial disease, this is a particularly important item because not all of these drugs work in axial or spinal disease. You'll see that really there are three items on this list that would be particularly facing the psoriatic disease patient with skin and axial disease or a joint axial disease. Those are TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. Those three listed. Important to highlight that, for example, methotrexate, which is used frequently still in rheumatology for psoriatic arthritis, despite some lack of data, it does not treat axial disease. For example, IL-12/23 inhibitors do not treat axial disease. And at present, we do not use IL-23 inhibitors for axial disease, although there are some ongoing studies to ask whether or not that is the case in axial psoriatic arthritis. So stay tuned. You can also see there's efficacy been shown, although variable, if among these agents for dactylitis and enthesitis. Another important distinguishing point is in IBD, where, in fact, we have approvals of drugs like TNF inhibitors, 23 inhibitors, and JAK inhibitors, but we tend to avoid IL-17 inhibitors in patients with active IBD. I would also likely avoid it in patients with a history of IBD if I have other options to use. I don't avoid it if a patient has a first-degree relative with IBD. If I need to use them, I think it's reasonable with the discussion. The other point that's on here that's in red is inhibition of radiographic progression. You see that in the box. And so that's another distinguishing feature. Alice mentioned this in her summary slide, that we have really three agents with the double asterisk there that have shown inhibition of radiographic progression: TNF inhibitors, IL-17 inhibitors, and several JAK inhibitors. That's particularly important when a patient has deforming arthritis, more aggressive arthritis, and certainly something that you want to keep in mind in that context. Now, I have a slight bit of a cheat sheet version of that. I won't go into it in great detail because we covered that already, but at least among biologics, here's a slightly easier way to look at those domains of disease and radiographic progression. The green is, a strong support for use in that domain. The yellow is a good support, but perhaps there's head-to-head data or other data suggesting that other agents may be slightly better. And the X is the case where, in fact, those agents have not been shown to be helpful or have not shown benefit in that domain. The other decision point we have to make is what comorbidity or coprevalent disease does a patient have, and how can we align therapy either to treat that comorbidity or at least to be compatible with that comorbidity. And again, in the interest of time, we won't go through all of these. Our psoriatic disease patients have multiple potential comorbidities, metabolic syndrome, mental health comorbidities, among others as shown here. And so, for example, one more obvious that might come up is the use of methotrexate, where you would tend to avoid that in patients who have metabolic syndrome, perhaps liver disease, as an example. So, in summary, to the treatment piece, obviously Alice covered at great length this idea that it really is imperative to screen for psoriatic arthritis among our psoriasis patients, and it can be done in a low burden way using the PEST PSET algorithm that Alice demonstrated, and that's being used, in fact, and piloted in an automated way in the EMR at Mount Sinai with her group at Mount Sinai at Beth Israel. And then we talked about a domain-based approach to treating psoriatic disease, asking first which domain is involved, then which comorbidities do I have to consider, as well as considering patient preferences such as dosing frequency. Is it, does the patient prefer oral or subcutaneous route? And with that, I want to certainly thank you for your attention. Alice and I, have done this with Medscape as a partnership, highlighting our masterclasses approach, where we really believe that dermatologists can learn best from the interface, from learning from other providers, meaning having a rheumatologist talk about psoriatic arthritis, et cetera. And Alice, I don't know if you want to add a few comments about this, but we'd love to have folks continue this sort of learning journey with us along the masterclasses line.
Yes, I'd be delighted to. There are two meetings, the one on the bottom on February 20 to 23 in Sarasota at the Ritz-Carlton. What makes it, I think, unique is its multidisciplinary teaching of dermatologists who want to be truly up-to-date and want to be able to handle complicated cases. And so we have rheumatologists, gastroenterologists, oncologists, surgeons, we have, of course, dermatologists teaching variety of areas. For instance, we have concentration on connective tissue disease, hidradenitis suppurativa, on psoriasis, psoriatic disease, including inflammatory bowel disease, on atopy, on class 1 immediate urticarial kind of diseases. And so it's in an intimate environment such that attendees could interact with the key opinion leader faculty. And so I think this is rather unique. We also thought that since many of our prescriptions are being written by nurse practitioners and PAs, both in rheumatology and dermatology, that it's important that they know a lot about these diseases and their various treatment options. We also felt that medical science liaisons from industry, they may know a lot about their drugs. They don't know, in general, a lot about their diseases. And all three of these groups, we had an inaugural meeting in the Ritz-Carlton, Las Colinas, Dallas, Texas, last year in the first week of November. It's being repeated November 1 to 3 in Las Colinas, Dallas, Texas. And one thing that we're doing, we have both rheumatology and dermatology APPs and MSLs, and the registration in the masterclasses in psoriatic disease for APP Plus is free for attendees. And so we want to encourage folks to come, and we look forward to seeing you at either of these meetings or both of these meetings.
Thanks so much, Allison. I'll just end by saying we're really delighted that Medscape has also embraced the interdisciplinary teaching and having some rheumatologists and dermatologists come together to hear about psoriatic arthritis. So just a huge thank you to you all, and we hope you enjoyed some of this content.